Welcome to Let's Clear the Air, a podcast sponsored by the Allergy, Asthma, and Sinus Center, dedicated to educating listeners about allergies, asthma, and immunology.
Welcome to this episode of Let's Clear the Air. This is Marcella Feathers, and I have the pleasure of being here with Dr. Cline. Hello, Dr. Cline.
Hello, how are you? Welcome
I'm doing well. Oh, we're glad to have you. Welcome back to the show. Today we're going to talk about a bill that was reintroduced. It's the PAVE Act. So that's the Penicillin Allergy Verification and Evaluation Act. And that's significant. Why? Let's just talk about that.
Yeah, I think it's a good thing to eventually have built into the Medicare wellness visit. There's a lot that's going on during these visits as far as routine screening, like trying to get colonoscopies, any breast cancer screening. So I think this is another good one because there are a lot of patients who get misclassified as having a penicillin allergy who may not actually have one. And so as time marches on, or even at that point in life, a lot of patients may have been treated with alternative antibiotics for years and years and years for sinus infections or pneumonias or bronchitis and you name it. And having that cleared and being able to be treated with an appropriate antibiotic, which penicillins, even though they've been around for, many years, are still probably the most powerful, cheapest antibiotics that we have at our disposal. So being able to clear that allergy is very beneficial.
Sorry to interrupt. Real quickly, the Academy requested that this be introduced. And according to, this is the American Academy of Allergy, Asthma, and Immunology, they were saying that 9 out of 10 patients say they have a penicillin allergy, but actually do not. Why is that?
Yeah, I think a lot of people get misdiagnosed for just lack of recognition of other things that can cause hives or rashes, especially in childhood. One of the most common causes of hives that we see is just viral illness. And so getting an adequate history of the timing, what symptoms occurred. And most of the time when you go back and backtrack, a lot of those can, just based on the history, be actually cleared. And we see a number of patients who, may have been misdiagnosed as a penicillin allergy, but then, last year they're like, oh, I took Augmentin or amoxicillin, which is a penicillin. So that, lack of recognition. And so a lot of people just kind of get put inappropriately into the bucket for, any rash that occurs. You were on a penicillin, so therefore you're penicillin allergic, when it's not necessarily that simple.
And is that typically the allergic reaction you would even have to a penicillin if you're allergic? It would be hives?
Yeah, usually it would be what we say is things that kind of send it up the differentials. First dose and something plus hives, so hives plus, shortness of breath, hives plus dizziness, passing out. The true reactions that I've seen are usually pretty extreme, so it's not something as simple as, not necessarily just a rash, but a lot of it depends on the timing, like what did the rash look like, how many days in, because usually the penicillin and other drug allergies themselves are going to be first dose. So like when you take that first dose, it's going to be some level of anaphylaxis upon that first dose. So not necessarily just hives, although it can be that, but there's a lot more to that equation. So
the PAVE Act, if I understand it correctly, is asking that for Medicare patients during their wellness visit that be revisited to confirm or negate a penicillin allergy, right?
Right, exactly. And they have a number of tools that even primary care providers can use. There's one called PenFast where it's easy to access, I think even from MD Calc, where you can go through and see like what's the level of concern for that penicillin allergy. And if from a primary care standpoint you're concerned at all, the easiest thing is just to send to the allergist because we have the skin testing available. But the skin testing is only a part. I always try to tell patients that the skin testing is just to provide more information, and most of the time it's not even really necessary. A lot of times the current guidelines actually recommend skipping directly to a challenge, whereby you basically consume amoxicillin or Augmentin here in the office, and that is the gold standard for clearing the allergy, so not necessarily just the testing. So that's something that not necessarily the primary cares may not feel comfortable doing, but a lot of the guidelines have now changed to where they can use this PenFast tool and then try to risk stratify them. And if they feel comfortable with it, they could do it in their office if they wish. Now, most of the time, they're still sending them to us, which is perfectly reasonable. We enjoy seeing those. I like the treatment of drug allergy. It's It's very interesting and satisfying to remove allergies when they come. A lot of times we're adding them or trying to see if they're there, but like we have the testing in house, so if we feel that it's warranted, we'll do it, and then also follow it up with a challenge either that same day, which is a long visit, or another day.
What is the PinFast? What is that exactly?
So it's just like an extra tool that goes through and tries to get the timing of the reaction, like how long ago was it, and so it has a number of questions. Yeah,
okay.
exactly. So like, was it 2 days after you had the antibiotic? Was it the first dose? What was the rash? Have they had it since? How many years ago was the reaction? So a lot of times when it talks about in the penicillin allergy data, that a lot of it depends on when that reaction took place. So if it was more than 10 years ago and it was something that was many doses in, that would be a person that would be appropriate for challenge. And if it on the other side of the coin, if it was yesterday and you had, anaphylaxis, that's a person you may give some time and then test for and that kind of stuff. But in my many years of testing, I've only seen actually 2 people show up positive, and they both had convincing histories. But you have to be very careful with the testing, because if you test everybody, then you can run into false positives, and people may then avoid the antibiotics unnecessarily. So we can see some false positives, but penicillin testing is one of the ones that's been vetted for many years. It's validated. We kind of understand what the results mean, but it's also still just supplemental information. So even if it showed up positive and they had a rash when they were, 2 years old, and it would sound like it was something that's non-suspect, you could still technically challenge. Now, most people aren't going to do that, but again, it's just more of supplemental information. So that PinFast tool is something that can be very useful for the primary care doctor if they wish to do the challenge.
Right.
But again, most of the time they're sending them to us.
Yeah, and one of the things that we've talked about before on this podcast is that whether it's a food challenge or what have you, if you are going to have that challenge, we're better to do it than the allergy practice, because they are best equipped to recognize when you have an anaphylactic reaction, or be able to help you quickly and in the best way.
Yeah.
So, and it's interesting because a lot of folks, I think, have been diagnosed with this at a young age. So their history is going to be, as you mentioned, 10 years or plus. And you talked about how penicillin is effective and cheap. So I think the negative side of having an historic allergy to penicillin, but not a confirmed allergy to it, is it's pretty risky, right? I mean,
right, exactly. Yeah, there's a number of agents that may not treat it as well. They're more expensive than the penicillins, so it just increases healthcare cost, which is obviously one of the big problems currently. Is trying
this has been introduced,
right?
Right,
exactly. So to try to keep costs low, keep effectiveness high, and so we don't want to avoid things that could be used to easily and more cheaper alternatives and stuff like that. So you can imagine if people have a number of antibiotic allergies and they pile up, and penicillin is one of those, then you're getting these alternative antibiotics either in the hospital or outpatient setting. They're harder to get a hold of. They're more expensive, so people's cost is getting higher and higher. So I think it's a wonderful idea. I wish we could clear more of these. I wish we would get more of these consults. So I think after this takes place, then we'll probably see a number of consults come through for this reason, which I think is great. Anything that can keep costs low, I'm a big fan of.
Yeah, and help the patient in the end, the fastest
exactly.
and most efficient way.
Yeah.
And we were talking about how even though it's Medicare patients or Medicare specific, if you are on a private insurance or what have you, you can still request to have this, right?
Yeah, exactly. Yeah, it's a very straightforward consultation. A lot of it's protocolized, like we talked about. It's like using kind of our clinical acumen to decide, do you need testing or or can you go straight to challenge? Because I've had patients that have done both things. I've had a number of patients who've gone straight to challenges with success. Had patients who, even after the discussion, they prefer to do the skin testing and the challenge. So it's really up to them, but I think it will be, an excellent tool going forwards. But if they want to request it with their primary doctor, I'm all for it. I think that's it's a great tool to try to eliminate that. if we can. And a lot of times when patients are coming in for other reasons, if I've noted in their documentation that they've listed it, then I'll talk with them about it and see how much they want to do there today. They may be here for other reasons, and if they mentioned it, I'll try to capture those people if I can, and try to test them if I can. A lot of times patients aren't able to stay for the whole challenge because after you've done the whole skin testing and listened to me talk, no one really wants to be in the allergy office for 4 hours. So that can be a very long visit.
Well, but we can set up different separate times for that, right?
Exactly.
And that should be a fairly quick follow-up appointment.
Yep.
All right. Well, we hope that this actually goes into effect. I mean, it could help a lot of people, I believe. As you said, have cheaper costs and be more efficient and effective should they have any type of infection or issue where they need some antibiotics of sorts, penicillin being how long has penicillin been around?
That's a great question. I don't know the exact date on that, but several decades, if not hundreds of years. I'd have to backtrack and look exactly.
We'll have to look that up. I might put that in the notes there because I think, if I'm not mistaken, it's been around for a while.
Yeah, exactly.
All right. Well, thank you, Dr. Cline, for this.
You.
And if you are out there and have been diagnosed as either a child or it's been 10 years plus with a penicillin allergy, we'd love to see you and help you verify that so you can get that off your record and be cleared for a penicillin dose should you need it. All right, and that does it for this episode of Let's Clear the Air.
We hope you've enjoyed this episode of Let's Clear the Air. Please consider following this podcast, and remember, if you want helpful and accurate information about allergies and asthma, our allergy experts are here to clear the air.